Okay, so here we go. Now the child has arrived, and we go through the checklist. And sorry, this checklist is in Swedish, but you can check out the North American one, or you can check out the ERC 2021 guidelines that are the same as this, or very, very similar, because they build on the same evidence. Once the child comes in, you will take your stethoscope, and you will be ready to do the first APGAR. All right, so here's our APGAR, and the most important things about the APGARs is heart frequency, this is breathing, and then you have skin color, muscle tone, and I guess grimacing, or the most important ones are these two, heart frequency and breathing, because these two, if these two are bad, then these three will become bad. So these two are the main ones. Maybe muscle tone is also good, important as well in and of itself, but these are primary. I would call these secondary. And the heart frequency, the thing that you need to remember is that a baby needs to have one over 100, 140, 160 is good, but between 100 and 140 is also acceptable, depending on the rest of the way the baby looks. The other one you want to remember is like below 100 or below 60. If it's below 60, then it's as if they don't have any heart frequency, and you need to consider compressions after you've done all of this AB work. Then you look at the breathing, and the one where you get 1 point, I think you should expand that to either be grunting. Grunting would be usually with wet lungs, and grunting is usually in a healthy baby where there's wet lungs, and these babies usually don't need the entire algorithm, they just need CPAP and stimulation and then a warm and dry environment, right? But if it's not grunting and it's something more than that, just that, or if the heart rate is low, then you'll begin on the algorithm. So let's do the assessment here. So I have the baby comes here, and if it's below week 20, gestational age 32, then you will not dry it with a towel, but you'll just put it wet in a bag, plastic bag, because the skin is brittle and it may peel off if you dry it too hard. But if it's a full-term baby, and you will dry it, I'll dry it a lot in the axillas and so on, and then maybe throw away always throw away the towel, get a new towel, and then so it's lying in a dry area. It's really important that they're warm, so that's why it's really important. And then you put your stethoscope here on the heart, and then you can beat the pulse with your finger, so everyone in the room knows what's happening. This is a good pulse, and then you can see if it goes like this, then it's slow, that's bradycardic, and then this is catastrophically low. So you can get kind of a sense of quite quickly how good the pulse is. The heart rate is like that. I usually have a hand here as well, so I know the tone of the baby, and also to maybe sometimes calm them down. All right, so, and then when we've done the drying, stimulation, and so on, then you do the reassessment and see, oh, well, has anything helped? And if the heart rate is still under 100, or the breathing is still abnormal, not just gasping, but abnormal, then you go to the algorithm. Before going to the algorithm, I'll just say if the baby is gasping, then usually you'll just take one of these, the neopuff, and don't do any ventilations, but just put the mask on the chin, and then like that. It's a bit of a big mask, this, so we can use another one here. We'll just take the smaller one here, and then put it in here, like that. All right. Then you see that putting it on the chin, and then giving a tight seal here. And just with a CE-grib, so C with these fingers, and then an E with the rest of the fingers below the mandible. Also pushing the mandible forward, like in a jaw thrust, and getting an even the pressure on the mask should be even with your fingers, not lopsided, because then there'll be a leak here. It's not important to press a lot, it's important to press evenly. And if you cannot get this even pressure, then you should do it by manually. And then be aware that you don't push the baby's softer parts down here with your fingers. It has to be the mandible, and it has to be forward, like that. All right. So, and the babies that are just grunting and have wet lungs because of a quick last phase of the pregnancy, or because it was a C-section and their lungs are not quite ready to get into the wild here, then just keep CPAPing them. Maybe you can do some of the 5 blows that the ERC recommends, but in general, from my experience, mainly pediatricians and neonatologists would just CPAP them. And you can hold the baby like this, and then you can CPAP them for maybe 5-10 minutes, and then reassess, see if anything is happening. If they're still grunting and using a lot of word of breathing, then you have to consider giving them a nasogastric tube, because so the stomach won't blow up. And you can consider giving them glucose early on, especially if they're big babies or very small babies, because this word of breathing is hard for them and they need feeding, which they're not getting out here. And then oftentimes, if it takes more than 10 minutes and they're not getting better, then you usually would just go to the neonatal unit for a couple of hours to get a proper CPAP on them in the nose, because they're obligate nose breathers, right? Where they something in their mouth so they don't open the mouth, and then they can be there for a couple of hours, and then usually come back to mom after that. All right, but if it's not just grunting, if it's inappropriate breathing or apnea or heart frequency below 60, then you can move to the algorithm here. And even if the algorithm says, like, if it's heart rate below 60, then you still do this first. And then it's as a matter of opinion, the ERC guidelines would say that you have to do 5 long inhalations for 2 to 3 seconds. This guideline will say that you have to do directly go to ventilations, just 60 per minute. So it depends, but I would say if the child is really, really ill, then you will probably just go to ventilations right away and not bother with doing 5 and then reassess and then do 5. But the main thing here is that you get some air in the baby, and that you make sure that the chest is moving as it should, and that the saturation is going as it should, depending on the baby's age. And if it's not, then you can always increase the saturation a bit. All right. So we put on the mask, and you do your either the 5 ones, like 1, 2, 3, 1, 2, 3, 1, 2, 3. And the rhythm here, I've lost my rhythm for this, so please check other videos for the rhythm, but it's something like that. So 2 or 3 seconds for these long breaths, and then reassess after that. If the chest has been rising, then you can, and they're still not in a good way, then you can continue with ventilations, 60 per minute. But if the chest is rising, if the chest is not rising, then you have to redo something. Usually it's moving the head in a better position. It may be a suctioning of the mouth and the nose. It may be doing some more advanced stuff along the way, but in general, that's the first steps, right? I forgot to mention your teammates have probably already put on your saturation monitor on the baby's right hand, and these ECG monitors on the chest, so that you don't have to use the stethoscope, but you can see on the monitor what the heart frequency is. All right, so all of this part of the algorithm and in the ERC and this focuses on you must be sure that that the baby is getting air into their lungs. And if you're sure that they're getting air into the lungs, and when you reassess after 30 to 60 seconds and the baby is still not still not either breathing normally or have still a low heart frequency of below 100, then you will consider doing other stuff. You may give it a bit more time if it's below 100 only, but if it's below 60, then you will go to compressions right away, right? But if it's below 100 and they're kind of breathing okay, and you continue with this, maybe you'll consider doing some more advanced stuff like laryngeal intubation or laryngeal LMAs. Like 90% of births, they don't need any help like this, and the 10% that come out here, only a minority, very small minority, go to this part where the heart frequency, despite all your efforts here, still is low. So this is really now becomes the neonatology part. The part I just explained is probably what we need to know as emergency physicians. But if you want, and I've only stood in these situations a couple of times where they need to be this part. So my experience here is lacking as well. But I'll give you my point of view and also my reading of the guidelines. So what we need to do now is to so the baby, despite us having ventilated them for 60 seconds and the chest is rising, and we see that there's good breath and everything is like as good as it can be. The baby's warm and so on, and it's dried and stimulated. But still the heart rate is not going up. Then we have to, if it's below 60, then we have to go to compressions. You do a double underhand. I cannot do double underhand because I'm holding the phone, but you do a double underhand compression like this, 1, 2, 3, and then the one in the airway at doing the psst, and then 1, 2, 3, and then the one in the airway is doing psst. So you say this out loud while you're doing it, and while this is happening, you are usually preparing for intubation, and you are trying to get vascular access. You can either do an IO, which is a temporary measure. It's very difficult in these neonates to do it, and it doesn't usually stick for long. So it's very, very temporary, and that's why I would urge you to learn this instead. It's easier. And you'll use the venous, so the umbilical vein catheter. So the red one is the vein, which is paradoxical from the normal anatomy, but this is the red one, and you usually cut a little slice and then dry it off, and then you can put it in. And I've never myself put these in, so check specific videos for that if you want to learn that. Then what you can do now, once you have a vascular access, you can give them adrenaline, and here are the doses for adrenaline, and you can give them fluids. But it really depends now on like differential diagnostics. And meanwhile we're doing all these things, we will listen to the lungs, maybe do ultrasound if you have that available, and see if there's pneumothorax, if there's any other reason. And in my experience, usually there is a reason that is already known, either from in utero diagnostics, maybe heart problems, or a mom that has been preeclamptic or something like that makes the baby being in such a way. So it's usually expected. It's very rare for this to be unexpected, but it does happen sometimes. Okay, so and at this point, the baby will then be intubated. You will be doing these compressions, and you will hopefully have a neonatal team at the ready to go up to more advanced diagnostics and therapeutics. Yeah. So that's in short my experience and my reading of the algorithms for neonatal resus. I think this is really important because this is something that we may have to do maybe once in a lifetime, once in a career, and now you have a video that at least shows some of the basic steps that I think is reasonable to take. All right. Here at the end, I'm considering just showing you how to fold this towel. You can pause the video here and then check out this. Also, where to put the ECG leads, the APGAR score, and the head position. And yeah. And then of course, sometimes we forget that you have DOPE's algorithm. The EmCases also have a MrSOPA. You can check out the EmCases videos on this for when the airway is obstructed or there's a problem with the airway. That's the DOPE's. And you always have to check out for the parents as well. Have someone explain to the parents what's going on and what's happening, and especially if it's just wet lungs, then you can explain that it's perfectly normal when everything has gone really fast, and they usually it's not a big deal, right? Yeah. But I'll end the video here, and thank you so much.